Hi, student. We are talking today about management of client with renal and urinary disorders. Next slide. So the function of the kidney is very, very important. You have your vasodirector, which are a specialized cell that monitor the blood pressure. And renin is then excreted, by angiotensinogen 1, and then angiotensinogen 2. You know that angiotensin 2 is the most powerful vasoconstrictor known. Aldosterone will be excreted in response, to any type of pituitary, to the pituitary in response to like poor perfusion or increase in osmolality. The renal clearance, which is important, is the ability of the kidneys to clear solute from the plasma. So this is another very important function. Creatinine is the waste product, of the skeleton muscle that is filtered at the glomerulus and excreted in the urine. So the kidneys take a role in that. Erythropoietin, in response to low oxygen tension, is released. It's another important function. And then the kidney finally converts inactive vitamin D to active form, 1 to 5. So it's important again. So mind you, when there's a problem with the kidneys, this ability of regulating water, of regulating electrolyte, of regulating acid base, and regulating the blood pressure, and also making red cells, it's impaired with the kidneys that is not working well. Next slide. And as you see in this slide as well, the kidney is the major organ that excrete waste, and that includes urea, creatinine, phosphate, uric acid, and it also metabolizes drugs. Next slide. The renin-angiotensin system is very important. You know that the renin is excreted and is usually prompted by some decrease in the renal perfusion, and or decrease in salt delivery to the kidney tubules. For example, someone who's hemorrhaging, someone who has heart failure, someone who's taking loop diuretics. And when that happens, there's an increase in blood pressure, and there's a process of converting, angiotensin 1 in the liver, and then you go into angiotensin 1, and you know that angiotensin 1 has to be converted into its active form, so it needs some type of enzyme, and that enzyme is angiotensin converting enzyme to convert that into as the angiotensin 2. And then what you see is that an increase in blood pressure, and because there's vasoconstriction, there's increases myocardial contractility, and prostaglandins is then released. And this increase in circulating volume causes, by aldosterone, and then the sodium and water reabsorption, and potassium excretion, and of course ADH release. All right, next slide. So pretty much this is what I've just discussed further, and you're seeing what has happened here. But you see what you see here is the natriuretic hormone, which is also very important. That's natriuretic, natriuretic, which helps release from the cardiac atrium in the brain, and this is usually seen, the BNP. It's seen when someone has like a heart failure. Next slide. So there are some risk factors when it comes to kidney problems or renal problems. Some of the risk factors that you will see that put the patient at risk will be hypertension, diabetes mellitus, immobilization, someone who has Parkinson's disease, individuals with lupus, gout, individuals with sickle cell anemia, individuals with multiple myeloma, BPH, pregnancy, and spinal cord injury put those individuals at risk for some type of renal or urologic condition. Next slide. There are some gerontologic consideration when you're caring for clients with renal diseases. You know that as someone gets older, the GFR also decreases. The renal reserves decreases. The multiple medication, because a lot of elderly folks are taking polypharmacy, and so because of these different drugs that they're taking, put them at risk for toxicity. There's also decrease in osmotic stimulation of thirst. There is incomplete emptying of the bladder, and of course urinary incontinence. Next slide. So now we're going to be talking about urinalysis, your diagnostic test that are used for kidney and urinary system. Next slide. One of the urinalysis is the most common urologic study that is used, and in that it looks at different things. It's going to look at your specific gravity, and normal specific gravity is 1.005 to 1.020. It also look at microscopically other things such as the red cells, ketones, glucosuria, and presence of bacteria. Leukocyte esterase is usually used, an enzyme found in WBC. Nitrate, the bacteria convert nitrate to nitrate. So you see this when you're trying to diagnose like urinary tract infection. Osmolality, an accurate measurement of the kidney's ability to concentrate the urine. In normal ranges is usually 1500 to 1200. And then the culture is also important, and in this culture we're trying to examine the pathogen that is causing the current situation. Next slide. Continue on with the urinalysis and urine test. You also look at albuminuria, the albumin in the urine that is not measured by a dipstick. So normal values is freshly voided sample usually will collect a fresh sample, and what you want to see the range is 2 to 20 for men and 2.8 to 28 for women. Higher level indicate micro albuminuria, so which tells you the kidney is having issues. They can also be determined by doing a 24-hour urine sample. Next slide. Renal function tests continue, and we're looking at the urine osmolality. This will tell us, the ability of the kidneys to concentrate. So the changes are usually seen early in the disease process. Creatinine clearance test. This would help. Is the test? It reflects the function of the glomerulus. Serum creatinine measures effectiveness of the renal functions, and it's usually 0.6 to 1.2. Urine nitrate, the BUN, also indicate renal function, and that number is 7 to 18, and it measures renal excretion of the urea nitrogen, a byproduct of protein metabolism. It's not always elevated in the kidney disease. This is why it's not a specific test. So by itself, it's usually not an indication that the kidneys fail. So this is why they usually measure your creatinine clearance as well. Next slide. Liver must function properly to produce urea nitrate, so the BUN levels indicate extensive renal clearance at the nitrogenous waste product. Like I said, you may also see a BUN at a higher level. You can see it with bleeding. You can see it with someone who is, who has some cell destruction from infection or steroids, or someone who is also dehydrated. All right, so you may see an increase in that. So that doesn't mean that the patient has kidney function, kidney impairment per se. Next slide. Also looking at renal function tests, looking at the ratio of the BUN to creatinine, also distinguish between the renal and non-renal factor causing elevation. So that really is going to help us, to help diagnose the current problem. Dehydration can also affect the BUN, I said that, and when the blood volume drops or BP is low, the BUN level also rises more rapidly than the creatinine level. So that will give you an indication too that it's not coming from the kidneys. Next slide. GFR is also another way to assess the ability of the kidneys. So the volume of the fluid filtered from renal glomerular capillaries into the Bowman's capsule per unit of time, generally expressed in mLs per minute. The normal GFR is 125. That can go as low as 15 in someone who has chronic renal failure. So it's really important measure for us to use. Next slide. So yeah, calculating the glomerular filtration rate is a very complex process. There's many different formulas that can be used, and you could just try to review some of them and see which one that you feel comfortable in using. Next slide. Creatinine is our next lab test that we're talking about. So there's one thing you need to understand, that there's no common pathologic condition other than renal disease that increases the serum creatinine level at all, right? So the serum creatinine does not increase until at least 50% of the kidney function is lost. Next slide. All right, so repeating what I just said, the serum creatinine does not increase unless 50% of the kidneys have lost the function, right? And there's no other diseases that can have an increase in creatinine level. So which means that when there's an increase in creatinine level, what you're seeing is kidney impairment. Next slide. All right, so creatinine clearance is also another test, and it's calculated measure of the glomerular filtration rate, right? It is the best indicator of the overall kidney function. And what happens here is that we, based on a 24-hour period, the urine is collected. Midway, after that, they will measure the serum creatinine level, so they'll draw the blood. And the serum creatinine levels vary with, of course, the age, gender, and the body size or mass. And how you calculate is the volume of the urine, multiply by the urine creatinine, and then divide that by the serum creatinine level. That's how you get the clearance. All right, next slide. Other tests that are used to measure the kidneys are kidney, urethra, and bladder test, ultrasound, CT scan, MRI, nuclear scan, and Voidin scan. So there's many different procedures to see how well the kidney is functioning. Next slide. Cystoscopy, kidney biopsy. You understand from our previous lecture why someone would want to do kidney biopsy. So what I want you to do is to go ahead and review all of these different diagnostic tests and tell me some of the nursing management that you need to pay attention to. Next slide. All right, glomerular diseases. So we're going to start talking about the glomerular diseases, and pretty much with this conditions, what you see is some type of antibody, complex that form in the blood, became trapped in the glomerular capillaries, and then that would induce an inflammatory response. And that this is happening because there's some clinical manifestation that the client may see, or you may see in the client, or you may see in some diagnostic tests such as proteinuria, hematuria, decrease in GFR, and alteration in the excretion of sodium. And so when you're not excreting sodium follows water, right? You see acute and chronic glomerulonephritis and nephrotic syndrome. Those are the glomerular diseases that we're about to talk about. Next slide. Acute glomerulonephritis. It's usually a condition that follows some type of streptococcal infection, right? So sore throat, somebody's complaining for sore throat for 2 weeks, right? And if we don't treat that, the complication of that is going to be glomerulonephritis. That's one of the systems that's going to affect. It also would affect the heart, right? And generally when this happens is you have sudden appearance in, hematuria, proteinuria, red cell cast in the urine, edema, and hypertension, and which would all lead to this cast in urine. And then you see a decrease in, scarring and loss of glomerular filtration membrane, and which means that it's not able to filter, leading to a decrease in glomerular filtration rate. Right? Next slide. So what are the infectious causes of it? Like I said, usually strep, strep infection, staph infection, CMV, mononucleosis, hepatic, problems such as Hep B, mycoplasma, and group A beta hemolytic strep. It's the most common one that we usually see. All right, so that's why it's important to ask about, sore throat weeks prior to the diagnosis. Next slide. So the clinical manifestation of acute glomerulonephritis include hematuria, like I mentioned earlier, edema, accumulation of waste product, urine appearance that may look like a color. The patient will be hypertensive. They will have low level of albumin in your blood. They have an increase in lipidemia in their lipids, and their BUN and creatinine level will go up because it's telling you that the kidneys are not doing well. Next slide. You may complications of this if it's not corrected. Of course, they can end up in renal end-stage renal disease, right? Heart failure, and of course, hypertensive encephalopathy. Next slide. So it is important for us to treat, and so treatment would be to manage the clinical manifestation that they have. Remember, they were hypertensive, so we're going to have to treat, to lower that blood pressure. We will have to monitor the GFR, by 24-hour urine creatinine clearance test. Monitor ANA, anti-nucleic, antibodies. Treat the strep infection that they had with antibiotic. Preferably penicillins. The steroids, immunosuppressive may be used. Of course, when the kidneys they are injured acutely, you want to restrict protein, but we know that protein is good for the long run because protein builds in repair. So less protein, which means that we've got to make sure that they have, available carbs. Restrict the sodium because they are edematous. It's really important for us to monitor them because we don't want them to progress to chronic glomerulonephritis, which will, lead to other problems. Next slide. The next condition is nephrotic syndrome. Nephrotic syndrome is a condition of increased glomerular permeability, right? It is not a specific glomerular disease. It's a syndrome with a cluster of findings, and usually include many different things, such as an increase in protein in the urine. Because the protein is in the urine, so you don't expect it in the blood. So you have hypoalbuminemia, edema because of third spacing, and high cholesterol and bad cholesterol, high total cholesterol, and high LDL. All right, next slide. So there's also massive protein loss, like we said, because it's in the urine, often linked genetically or some type of immune deficiency or any type of inflammatory process. So it's autoimmune. Can be caused by chronic individuals that have chronic glomerulonephritis, those that have diabetes, those that have lupus, myeloma, and renal vein thrombosis. The major manifestation, and again, is edema because you see the massive amount of protein that is being lost, right? And the hallmark is albuminuria, which exceeds 3.5 grams per day. That's a lot of protein. So clearly, imbalanced nutrition is a significant thing here. All right. Other manifestation that they may have is anorexia, and fatigue and oliguria. Next slide. So this is just showing you how having nephrotic syndrome can lead to hyperlipidemia. So you have the damaged glomerular capsule membrane, and then which causes loss of protein, which stimulate the synthesis of lipoprotein. Lipoprotein leads to hyperlipidemia, so you'll see high level of cholesterol for these guys. Next slide. All right, so you have the damaged capillary, glomerular capillary membranes, loss of protein, again, repeating what we've seen, but here what's happening is, there's low level of protein in the blood, and so you have a decrease in the oncotic pressure to pull things, right? So therefore leading to the edema, sodium retention, and sodium follows water, so edema. Next slide. So there are some complications of nephrotic syndrome. Again, they lost 3.5 grams of protein, so they have a massive proteinuria because they've lost it in the urine, so it's not in the blood. They are edematous, they have lipid issues, lipidemia, and increased coagulation and renal insufficiency. All right? Increased coagulation. So DVT, right? Next slide. So management of this syndrome is, first we want to find out the specific cause. So a renal biopsy is good. Steroids and diuretics, because of the massive edema. Immunosuppressive may be used. ACE inhibitors can help decrease the proteinuria. Cholesterol lowering agents, so Crestor, the statins, heparin to reduce coagulation, right? Limiting your sodium intake. But you're limiting their sodium intake, so we need to make sure that we're giving them protein, right? Because they've lost a lot of protein. Next slide. Acute renal failure is a sudden interruption of the kidney function for many things, such as obstruction or maybe decrease in circulation. It's usually reversible syndrome, whereby there is a sudden and pronounced loss of function. Right? It occurs over hours to days and results in the kidney failure to excrete the waste product. Remember, that's one of the major functions of the kidney. There are some people that are at risk for acute kidney failure. These individuals are people that have gone into, are in, or going through, or just completed major surgery. Those have major trauma. Those who are receiving any type of nephrotoxic medications, and of course the elderly. Next slide. There are three phases of kidney failure, acute kidney failure, or the causes of acute kidney failure. So it could be intra-renal, pre-renal, or post-renal, right? Intra, pre, or post. Here we're talking about intra-renal failure, and we're talking about injury or issues within the kidneys itself, right? So you have infection, blockage, polycystic kidney disease. So injury within the kidneys itself, right? So anything that can cause prolonged renal ischemia, or still under the renal. So you have like things that can be nephrotoxic. So nephrotoxic agents like aminoglycosides, radiopaque contrast, that contrast diet that you always tell, the client to make sure that they drink plenty of water to flush, that can cause acute kidney failure. Heavy metals, solvent, NSAIDs, ACE, or having acute glomerulonephritis can cause someone to go into acute renal failure. Next slide. Pre-renal It's about 60 to 70% of the cases. So many of the cases are from something outside of the kidneys, right? So the volume, here you have this, a depletion of volume, as seen in maybe hemorrhaging, someone who has renal losses from diuretics, someone who has GI losses, maybe from vomiting and diarrhea, or cardiac problems, MI, heart failure, dysrhythmias, or cardiogenic shock, or vasodilation from sepsis, anaphylaxis, or antihypertensive drugs, right? Because antihypertensive drugs will lower the blood pressure, right? So which would decrease perfusion, right? Next slide. Or you can have acute kidney failure or renal failure from post-renal. So the problem can happen pre-renal, so before the kidney itself. So something else that is happening before it goes to the kidneys, or the problems can be within the kidneys or after the kidney. So you know the urinary system, there is the kidneys, right? You can imagine what I'm talking about. The kidneys are there, and then you have tubes. Those are called the ureters that connect the kidney to the next thing called the bladder. So pre-renal is anything above the kidney that causes the acute renal failure, right? Pre-renal. Intra-renal, the problem is within the kidney itself. Post-renal is after the kidney. So what comes after the kidneys? Well, you have the ureter, the little tubes, and then you have the bladder. So things after that. So, of course, when you have an obstruction by calculi, so the stones, tumors, BPH, or blood clots, those can cause someone to go into kidney failure, right? Also, invasive procedures, like if you have edema, urethral edema from invasive procedures, can cause someone to have acute renal failure. Next slide. So there are phases or stages of acute renal failure, and it starts with stage 1, just the initiation, which occurs within the insult. Usually it's onset 1 to 3 days. Okay, and then you have the oliguric phase, low urine output, and it's usually less than 400 in 24 hours, and we say that we have to make a minimum for 30 cc's an hour, right? And what you see is there's a rise in potassium, the BUN, and the creatinine is not responsive to fluid changes at this point. And then stage 3 is the diuresis phase, so gradual increase in urinary output, right? But as much as 4,000 mLs per day. But what you see is that there's no waste product in that urine output. You have a urine output, but there's no waste. And then the last phase, which is the recovery phase, and that may take months, 3 to 12 months. But they may have some other permanent problems, in the functioning of the kidneys, about 1 to 3%. But overall, recovery, it's pretty good. Next slide. So with acute renal failure, and some of the subjective findings that the client may complain about is nausea, they've lost their appetite, they're having headache, there's lethargy, there's tingling in the extremities, and then you have more objective findings that such as hypotension, tachycardia, decreased cardiac output, decrease in urine output, and this is for pre-renal findings. In interrenal and post-renal condition, then you start seeing that there's, oliguria, anuria, hypertension, tachycardia, shortness of breath, apopnea, nausea, vomiting, generalized edema, weight gain. Weight gain is really significant indicator that, there's no excretion of fluid, right? Lethargy and confusion because there's accumulation of waste. So, of course, the client's going to present differently. Next slide. So non-oliguric form also exists. The phases are usually very similar. Next slide. So there's some laboratory profile. What you see is elevated in BUN and creatinine level. The sodium retention may be deceptive in this case because there's water retention. This potassium is going to go up, phosphorus is going to go up, calcium is going to decrease. H and H we're going to be decreased because remember the erythropoietin, vitamin D synthesis, and specific gravity decreases and fixed. All right, we may want to do a retrograde polygram, which is a retrograde, pyelogram is pyloegram, and so it's pretty much a urologic procedure where the physician is going to inject a contrast into the ureters in order to visualize the ureter and the kidney a little better. Next slide. So some of the objective pretty much when it comes to management of the patient that has acute renal failure is to restore the normal chemical balance and prevent complication, right? So it means that we're going to try to identify and treat the underlying cause, maintain the fluid balance, so monitoring the weight, CVP readings, blood pressure, and making sure that we are monitoring the eyes and nose very strictly. When we give them mannitol or Lasix, some diuretic to pull the fluid out, and they may need a temporary dialysis. So they may need temporary dialysis. So the different types of dialysis that they may have here could be hemodialysis. And hemodialysis, there can be several approaches. We can do subclavian approach or femoral approach. Or it could be peritoneal dialysis. It could be a continuous renal replacement therapy, that's CRRT. Pretty much the concept behind the continuous renal replacement technique is really to dialyze the patient in a more physiological manner or similar to the kidney, because it's done slowly over 24 hours, just like the way the kidney will be. So it's continuously, and it does not require any type of diazolate or fluid. Diazolyzed fluid, it doesn't need that. So pretty much it's a good, and usually this is done in the ICU. The ICU nurses are trained to complete or to perform this type of replacement therapy. Okay, so there's different types you can use: hemodialysis, peritoneal dialysis, continual renal replacement therapy. And again, the concept is really to mimic what the kidney would do, and it does not require any diazolate or dialyzed fluid. It doesn't. Regular dialysis involves a dialyzer, to complete the task. So these guys don't. Next slide. Okay, so if the prerenal fluid challenges in dialysis to enhance the renal blood flow, if it's oliguric renal failure, so usually they will give low dose dopamine. Dopamine is going to help increase the blood pressure, just give better perfusion to the kidneys. And it's usually that's a drug that is used again in the ICU. And when dopamine is given, we got to make sure that it doesn't infiltrate because it can cause necrotic tissue. And there is a special requirement, and the nurses, there's standing orders already if there's infiltration with dopamine, what to do. Next slide. Because of hyperkalemia, we have to monitor the electrolyte carefully to detect any cardiac arrhythmias. They will get some K-oxalate. There's high level of potassium, IV dextrose, insulin, and calcium may help shift the potassium back. We have to cautiously administer any medication that are nephrotoxic because these guys' kidneys are already in trouble. We have to monitor the ABGs and acid-base balance because remember the kidneys are helping in that process, and since the kidney is not doing well, that may be affected. And monitor the phosphorus level. Next slide. So now we are talking about nutritional therapy. Azotemia and uremia are directly related to the rate of protein breakdown. Right? They are. So dietary proteins are definitely individualized to each of the patient, right? Because protein, there's catabolic state, and if it's insufficiently taken, then the patient may lose up to like 5 to 10.5 to 1 pounds per day. So we encourage high carbohydrate and protein needs for patients that are dialysis is about 0.6 gram per kilogram of body weight. Dialysis patient would need 1 to 1.5. Fluid restriction equals the urine plus 500. Right, so whatever urine volume plus 500 ml. Next slide. So, what is your role? What is the role as the nurse? Well, pretty much to make sure that you understand the nursing process. Yes, pretty much understand the nursing process. You need to know the various nursing diagnoses that may be applicable to this client. So, for example, imbalance, fluid volume excess, right? You can see that. Altered electrolyte balance or electrolyte imbalance, altered cardiac output or decreased cardiac output, impaired tissue perfusion, renal, right? Anxiety, imbalanced nutrition, risk for infection, fatigue, knowledge deficit, right? So after your nursing diagnosis, you have to have a plan for each of these clients. So what are your plan for this client that has acute renal failure? So it's to promote recovery of optimum kidney function, right? And the question is how you're going to do that. To maintain normal fluid and electrolyte balance, to decrease anxiety, to increase knowledge, right? So what are some of your nursing intervention? So clearly we're going to monitor the eyes and nose, including all body fluids. We're going to monitor the lab results. We're going to watch for hyperkalemia, right? So some of the symptoms of that is malaise, anorexia, muscle weaknesses, EKG changes. We're going to watch for hyperglycemia or hypoglycemia if they're receiving TPN or insulin infusion, right? We're going to maintain the nutrition, safety measures, mild care, daily weight, okay? Assess for skin, impaired skin issues, provide good skin care. One thing you want to understand is that in kidney failure, the patient may have hypoglycemia. 3 different ways this could possibly occur. 1, the kidney help to generate new glucose from amino acids, right? That is called glucogenesis. But because the kidney has failed, this process is impaired, right? Also, insulin circulates for a longer period of time and is cleared slowly when the kidney function is poor, right? And third, the important reason is that the kidney failure reduces the patient's appetite. and no appetite, decreased oil intake, correct? So this is why we have to watch for hypoglycemia specifically, and hyperglycemia. Okay, next slide. All right, so now we're talking about chronic renal failure, end-stage renal disease. This condition is pretty much irreversible kidney function, right? Irreversible. And generally, dialysis is necessary, right? Dialysis is necessary because of the accumulation of uremic toxin, right? So what are some of the causative or the reasons for chronic renal diseases or end-stage renal disease? Well, the number one factor is diabetes mellitus. You have hypertension, glomerulonephritis, polynephritis, polycystic kidney disease, vascular disorders. All right, or it could be uremia, it's collection of waste product, right? And the kidney's job is to excrete that. And when there's chronic renal failure, this is impaired, and so you will see signs and symptoms that tells you that there's a buildup of waste, right? Such as headache, seizures, coma, dry skin, rapid pulse, elevated BP, scanty urine, and labored breathing. Next slide. So many changes occur with the kidneys when it fails. So the nephrons are hypertrophic and work harder, generally until 70% of the renal function is lost. The nephrons could only compensate by decreasing the water reabsorption. So therefore, you see some things such as hypostatinuria. All right, that is a loss of urine concentrating ability. Polyuria, increase in urine output, right? Or then the specific gravity becomes fixed. All right, so you have hypostatinuria, which is the loss of concentration. You have polyuria, and then you have isostatinuria, which is specific gravity is fixed. And then you have a gradual decline in urinary output. Next slide. There are stages of renal failure, where the glomerular filtration rate is usually higher, 9 mLs per minute. Remember, it was like 125, and then it decreasing gradually to stage 5, which is less than 15. All right. So kidney failure is when it's less than 15. You can have severe decrease in it, moderate, mild, and of course, kidney failure is defined as a GFR of less than 15. All right, next slide. So the clinical manifestation that you're going to see for kidney failure, it affects because, every system is affected. So you see all of that. So you see the various changes in the system. So you see the various changes in the system. For example, cardiovascular, you see hypertension, you see arrhythmias, pericardial effusion, heart failure, peripheral neuropathy, right? MI. Neurologic, you see changes such as burning, pain, itching, paresthesia, motor nerve dysfunction, muscle cramping, short memory span, apathy, drowsiness, confusion, seizures, coma, and if you do an EEG, there will be some changes. Renal, of course, there's dry mouth, poor skin turgor, confusion, salt overload, accumulation of potassium with the muscles, fluid overload, metabolic acidosis, proteinuria, glucosuria, and you see in the urine there will be white cells, red cells, and cast. GI, many changes with that: nausea, vomiting, ulcers, pancreatitis, ammonium breath odor, they call that vector, vomiting, constipation. Respiratory, there are changes there. So there's increased chance of having respiratory infection in the lung, pulmonary edema, pleural friction rub, dyspnea, Kussmaul's respiration. The endocrine, there's also changes there. You may see stunted growth in children, amenorrhea, male impotence because of the increased aldosterone secretion, impaired glucose level related to impaired carbohydrate metabolism, thyroid and parathyroid anomalies. Hematology, there's change there. You see anemia, right? Anemia of chronic illnesses. This is why they get erythropoietin. Decrease in red cell survival rate, blood loss from dialysis and GI bleed. There's platelet deficits. There's bleeding and clotting disorder. All right, musculoskeletal, there are changes there too. They have muscle and bone pain, pathologic fractures, blood vessels calcifications. The skin, there are changes. There's yellow brown skin with pallor. There's pruritus. There's purpura. There's uremic frost. There's thin, brittle nails. There may be alopecia. So a whole bunch of changes because the systems are all affected, right? Next slide. So this is the other changes that I described in the previous slide. So hematology, skeletal, metabolic changes. Next slide. So in terms of management, it's important, right? Management is important. So management is based on all of those things that are affected by the system. Remember all the system we just, kind of read. You have to manage based on those the symptoms that they have. So calcium and phosphate binders, right? So they take calcium carbonate, calcium acetate. They take antihypertensive drug, anti-seizure meds, erythropoietin, iron supplement in the diet, carbs and fat, and proteins restricted, right? And I know that with we've already looked at the lab test, the BUN doesn't indicate, necessarily that the kidneys are bad. We want to look at more closely at the serum creatinine level. Next slide. Medications, usually the medications do not work, so they need some type of dialysis because the kidneys needs to excrete the waste, right? So they need some dialysis, and there's the indication for dialysis is really, you see all the different problems that they have, abnormal electrolytes, uremia, uncompensated metabolic acidosis, right? It's uncompensated. Kidney's not able to compensate because remember the kidney is the one that gives you the best. It takes longer, but gives you the best compensated acid-base imbalance. Fluid volume excess, uremic encephalopathy, and of course to remove toxic substances. So really important for us to dialyze the client. Next slide. So dialysis is based on the principle of diffusion, osmosis, and ultrafiltration. Diffusion and removal of toxins and waste, right, from blood to diazolate. Osmosis, excess water is removed. It goes from an area of higher solute concentration to lower solute concentration, in this case the blood, and the diastole. The ultrafiltration is the water moved from high pressure area to lower pressure, right? Applied by the negative pressure, more efficient than just osmosis. Next slide. So there are some complications of dialysis, even though it needs to happen, but it does have its own complications. So some of the complications that you may see are arteriosclerotic heart disease. You will see disturbance of lipid worsened by the dialysis. There's anemia and fatigue. There's gastric ulcers, renal osteodystrophy. So sleep problems, hypotension, muscle cramps, dysrhythmia, and of course dialysis equilibrium from the cerebral fluid shift. Next slide. Dialysis disequilibrium syndrome is usually caused by rapid decrease in the fluid volume and blood urea nitrate level during hemodialysis. Right, so what happens here is changes in urea level, which can cause cerebral edema and thus increase in intracranial pressure. Right, some of the neurologic complications include headache, there's vomiting, there's restlessness, there's decrease in level of consciousness, seizure, coma, or death. However, the hemodialysis nurse is able to prevent this by starting short periods of hemodialysis and low blood flow. So it's important. Next slide. The forms of dialysis are, again, hemodialysis, and of course the continuous renal replacement therapy that's usually done in the ICU for clients who are unstable. Yeah, so the treatment again for chronic renal disease, because most of the time, dialysis starts only after all the other medicines have failed. And the three forms of dialysis are hemodialysis, like I said, continuous renal replacement for those in the ICU, and of course, peritoneal dialysis. All right, so we want to make sure that the dialysis usually about half of the patient with chronic renal failure eventually requires it. Diffuse harmful waste out of the product, out of the body, and control the blood pressure. So dialysis will help with that. Right? I would keep a safe level of chemicals in the body, and like I said, it does so by two ways mainly, and those two ways are the hemodialysis or the peritoneal dialysis. To just give you a little bit of review on the dialysis, peritoneal dialysis uses a semi-permeable membrane, right? So a catheter is inserted through the abdominal wall into the peritoneum cavity. It's usually less costly, fewer restriction, can be done at home for the client, but there are some risk factors for peritonitis, right? There's three phases to peritoneal dialysis. There's an inflow, and then there's a dwelling, and then there's an outflow, right? It could be they have automated peritoneal dialysis. Again, that is usually done at home, maybe 6 to 7 times a week. So it's usually done more frequently, kind of more consistent with what happens with us every day by using the bathroom. It's not just 3 times a week like in hemodialysis, right? So 3 types, continuous, it could be continuous cycle, it could be continuous ambulatory, it can be continuous cycle, and it could be intermittent, right? So versus hemodialysis, which usually happens, 3 to 4 times a week, and it takes 2 to 4 times. It lasts about 2 to 4 times, 2 to 4 hours, right? And the machine filter the blood and return it back to the body. All right. So There has to be some type of access to do hemodialysis, right? So vascular access can be a permanent one, usually using the subclavian or femoral, or it can be permanent. So the stent is placed in the arm, right? Can be done rapidly, and it takes about 4 hours, right? So for the permanent stent in the arm, so there's an AV fistula, right? It's usually the surgeon constrict by combining an artery and a vein, and it takes about 3 to 6 months to mature. Or you can have the graft, right, which is man-made tube that is inserted by the surgeon to connect the artery and the vein, and that takes 2 to 6 weeks to mature. So what does this mean for you as the nurse? Pretty much, it means that there's no blood pressure on that same arm as the fistula. We have to protect that arm from injury, control obvious hemorrhage that you may see, either from the artery, and maintain pressure. There's no IV on the same arm as the fistula, and a thrill will be felt, and this is normal, right? There are some problems, that can occur from these different devices. So one, there may be thrombosis in the AV graft. The AV fistula or graft may bleed, and of course, we are worried about infection, graft infection. There's something called still phenomenon, or another name for it is subclavian still syndrome. So it's pretty much where, some type of occlusion, so reverse blood flow in the vertebral artery, or the internal thoracic artery, due to some proximal stenosis. So, right, so there's some narrowing. So pretty much applying a small amount of pressure will usually reverse the symptoms. So some of our nursing consideration for these guys who are having dialysis will be making sure that the dressing remains intact. Do not push or pull on the catheter. We do not disconnect any of the catheter, and always transport the patient in bags as one piece, and never inject anything in the catheter. Some of the problems that are related with dialysis will be lightheadedness, so we give fluids. There's hypotension, there's dysrhythmia, and of course we talked about the disequilibrium syndrome, right? So some of the nursing diagnoses that you would suspect for a client that have chronic renal failure will be what? Excess fluid volume, right? Imbalanced nutrition, ineffective coping, risk for infection, risk for injury. All right? And so in terms of your nursing care then, based on this initial diagnosis, monitoring the eyes and nose, weighing the patient, making sure, that, they eat proper nutrients, assessing their mental status, their emotional well-being, let them discuss how they feel, that kind of stuff, and a lot of important education and care of the stunt and what to do with it. All right, maybe even have a medical alert bracelet. Next slide. So kidney transplantation is generally more successful if it's done before dialysis, right? And we want to make sure that there is compatibility. So we have to find a donor, right? And generally the waiting period is very long. The survival rate is usually 1 year. It's 95 to 97%. So a year to find a match. And one thing we have to understand is that The donor kidney is placed in the iliac fossa. Patient must be free from infection, right? They must take immunosuppressive for life because of rejection, right? So we have to monitor for fever, elevated temperature, pain, and over the site for the new kidney. In terms of the surgery, is very similar for any other post-op surgery. Next slide. So post-op, assessing for the rejection sign, such as oliguria, edema, fever, increase in blood pressure, weight gain, and swelling or tenderness over the transplant area, and of course monitoring for your creatinine level, WBCs, and monitor urine output. They may need a temporary dialysis, as we discussed initially. Next slide. Diabetic nephropathy. So this is a complication of diabetes, right? It's related to the extent, duration, and effect of atherosclerosis, hypertension, and neuropathy. So this is why it's important for us to help our client to be compliant with their blood sugar stabilization. All right, next slide. So it is a microvascular complication of diabetes. The first manifestation is usually persistent albuminuria. The diabetic patient are always considered to be at risk for renal failure, and also if they're taking a lot of nephrotoxic agents and dehydration, that also can put them at risk for compromised kidney. Next slide. So there are stages of diabetic renal disease. Stage 1, usually at the time of diagnosis of diabetes, the kidney size and GFR are increased. Blood sugar control can reverse the changes. But the problem is non-compliance, the diet and the medication. Stage 2, which is 2 to 3 years after the diagnosis, baseline membrane changes result in a loss of filtration, surface area, and scar forms. And then these changes are glomerulosclerosis. Next slide. And then in stage 3, that's later on, 7 to 15 years after the diagnosis, you start seeing microscopic changes. So albumin in the urine, and then GFR may be normal or increased at this point. Stage 4, the albumin is detected by dipstick, and then GFR is down. Blood pressure start going up, retinopathy is present. So now you start seeing other changes. Stage 5, the GFR goes down at the average rate of 10 mLs a year. Amazing. Next slide. So now we're talking about conditions of the lower urinary tract infection. So cystitis and urethrovesical reflux. So inflammation of the bladder or things refluxing back into the kidney, right? For many different reasons that could occur. Many different reasons that can occur. All right, so backflow of urine from the uterus going back to the kidneys. We don't want that, so clearly there's some type of obstruction, right? Post stuff that is causing the reflux. Next slide. So if it's bacteria in the urine, the culture should be done, right? So if there's bacteria in the urine, which it shouldn't be, then the culture should be done in all the individuals. So male, children, diabetic client, those have recent instrumentation, those that are hospitalized, those who live in long-term care facilities are all the risk, right? Pregnant women, sexually active people, or post-menopausal individual. Next slide. So these are the contributing factors on obstruction. So stones, tumors, diabetes, gender, specifically female because our uterus is smaller, male, age, conditions, individuals who have deficiencies in estrogen, neuromuscular conditions, sexual activity, alkaline urine, or reflux of urine. All right, next slide. So the most common organisms, E. coli, it's right next to the rectum, right? Other causative agents are Staphylococcus, protease, and so forth. Next slide. So the treatment is, well, before you treat some of the manifestation, urinary frequency, dysuria, pain, right? Urgency. So we got to treat it. We got to find the cause, or the precipitating factors or the risk factors, and treat it in inquisitive fluid, so antibiotic, teaching them how to wipe clean, the proper way to wipe, and avoid urinary irritants, bubble bath, those kind of things. Sometimes, and when they take an antibiotic, you got to teach them about those who are sexually active, that the protective mechanism for pregnancy may not work with antibiotic therapy. Next slide. Acute glomerulonephritis, not glomerulonephritis, polynephritis, right? So this is a kidney infection, so upper urinary tract infection now. They're more sicker than just a cystitis. Cystitis usually don't have chills or fever, right? But these guys do, and it's sicker, so they look sicker. And if you assess the kidney area, the CVA will be tender. Sonogram and CT scan to rule out things such as obstruction, but urine culture and sensitivity test can be done. Next slide. So treatment is hydration, antibiotic therapy. If they're nauseous and vomiting, antiemetics. They have to take the drugs, Bactrim, for example, gentamicin. Pregnant women are usually hospitalized because we're concerned that they may have early labor, and follow up with culture. Next slide. Adult void and dysfunction. So there's certain dysfunction that you may see in the adult population: stress, incontinence, so involuntary loss of urine, with activities such as coughing, anything that increases the intracranial pressure, intra-abdominal pressure, coughing. And then you have urge incontinence, unable to suppress signal from bladder to brain. It's like, I gotta go. Overflow incontinence, when the bladder is distended, will have small amount of incontinence. All right, functional incontinence, as seen in Alzheimer's. Reflex incontinence, as seen in individuals that have spinal cord injury. Stress, you have a mixture of it, stress and urge, and then neurogenic bladder, usually lesions of lesions in the nervous system that leads to urinary incontinence. All right, so your diabetic can have that. Your spinal cord injury person may have that. Next slide. So many things can cause it. Diabetes, spinal cord tumor, spasticity, flaccid. So pretty much we want to treat it. So many things with neurogenic bladder. There's a problem, that signaling from the brain, right, to the bladder. So the bladder, there's lack of bladder control due to the brain, spinal cord, or nerve problem, right? So many things, the MS, spinal cord injury. So they're not connecting, which is really, really important. Okay, so normally the brain is able to to tell, oh, my bladder is full, so therefore it needs to empty. With neurogenic bladder, it's not able to do so. And again, just to summarize, it's usually due to some type of neurologic condition. So you see that very commonly with someone who has, spinal cord injury, MS, and so forth. So the reason why we're so concerned about neurogenic bladder, because it can lead to a complication that it's really severe. So they are more prone to infection, urinary tract infection, stone formation. But the medical emergency that is associated with this neurogenic bladder is autonomic dysreflexia, right? That's DYSREFLEXIA, right? It's a medical emergency, right? Because the message that the bladder is full cannot reach the brain, right? And because the message is blocked, it leads to arterial vasoconstriction, hypertension, which causes vasodilation of the heart and brain, leading to bradycardia and dilation of small blood vessels to compensate. If left untreated, the patient has severe hypertension with systolic as high as 300 and stroke, coma, and death, right? So this is why we have to make sure that it is addressed, and individuals who have a problem where the bladder, the message is never, reaching, so they usually have either intermittent, cap them, or they have continuous Foley catheter inserted, right? So it really is something that we have to pay attention to as nurse. Next slide. So, what are some other factors contributing to urinary incontinence in the elderly people? Diuretics. So the nurse who decides to give diuretics 10 p.m., right? When they're sleeping, will probably create a opportunity for incontinence. Central nervous system depressant, right? Those who have stroke, those who have Parkinson's disease, those who have depression, altered self-esteem, those who are not able to ambulate. If you're not able to ambulate, you can't go to the bathroom. Assistant product costs also, and of course, those who have UTI. Next slide. So there are some pharmacological management, TCAs, anticholinergics, estrogen in women. And make sure that you review the different drugs and how the nursing interventions that are required for each of these drugs. Next slide. Therapy for incontinence, weight loss, in individuals who have that are obese, because it would help with the intra-abdominal muscle, fluid management, especially nighttime, transvaginal or transurethral electrical stimulation. They have inflatable devices, the cone exercises, Kegel exercise you can cap them. Scheduled toileting is really good, so every hour you can make rounds. Pelvic muscle exercises. Those are all possible therapy for incontinence. Next slide. Urethrolysis. Okay, so this is presence of calculi, stone in the urinary tract, right? You don't want stone, right? So when there's stone, you are worried about, pain, right? Because pain, that's what they complain about, so that it can pass, right? You want it to pass. Nephrolysis is formation of stone in the kidney, right? So urethral and kidney and nephrolysis. All right, so stone. So you could just imagine that the, nursing diagnosis is pain, but it obstructs the flow, perfusion, and so forth. And so you are concerned about other conditions such as renal failure from these stone formation. Next slide. So formation of stone involves 3 conditions: either slow urine flow, right, which leads to supersaturation, damage to the lining, or decreased inhibitor substances in the urine that can otherwise prevent supersaturation, right? Next slide. So what are some of the etiology? What metabolic risk factors? So those who have high level of uric acid, right? Calcium, those who take high calcium, right? Unless there's metabolic or renal tuber defect, those that are immobile, those who have urinary stasis, those who are dehydrated, urinary retention. These are all possible etiology. Next slide. So in terms of diagnostic, so we need to evaluate for any bladder obstruction. UA can reveal the red cells, odor, turbidity, which is like the cloudiness of the urine, white cells. You can do an MRI, KUB, CT scan. You can do a CT scan, IV urography will show obstruction. Next slide. So treatment-wise, they're going to be in pain. So pain, avoid NSAIDs, hydration, strain all the urine so to see if it passed, right? Lithotripsy is also another management or treatment option, and this seemed to work. So pretty much what they're doing here is breaking down the stone with the waveform, and because it's a waveform, those electrical signals, you have to monitor the EKG, right? And the patient is sedated. Minimal invasive surgical procedure may be done, right? So they can put a stent, right? Stent can be put in. Next slide. Antibiotic can be used. These are diuretics for hypercalciuria. Allopurinol, because if it's caused by an increase in uric acid, vitamin B6 for oxidate containing stones, uric acid stone, you give them allopurinol. Cysteine, captopril can be used as well. So many different ways, but one of the main nursing role is to monitor the urine and making sure that it passes. When it passes, the patient will definitely show you that it happened because they will be pain-free. Next slide. Okay, so bladder cancer is cancer of the bladder, and it's usually referred to urothelia, which means the cancer is in the urothelium. What you see is usually cancer that is non-invasive can be treated with BCG, which is a live vaccine. It's an immunotherapy drug. The patient takes it for about 6 weeks, and then there's a break time. But also cancer, generally cancer can be treated other ways. For those that are invasive with radiation and chemotherapy. Radiation, make sure that you review the different complications of radiation and chemotherapy that the patient may experience: nausea, vomiting, alopecia, low levels of white cells, red cells. So make sure you review all of those necessary complications of radiation and chemotherapy. Let's see what else is, pretty much, for someone who, how do you know that someone has cancer of the uterine, of the bladder? They may have painless hematuria. That's like classic sign. Smoking is a risk factor for this. And, once they are experiencing those symptoms, then they can definitely see their physician. And what would happen is, once it's diagnosed by biopsy, then they have this different treatment option with the BCG, radiation, and chemotherapy. Or they can also do surgery. Surgery, they can put conduits in place, to divert urine from, into the large intestine, so other, the patient may not need a stoma and so forth. So they can put a reservoir, a pouch that is created externally. So the major issue here is making sure that the cancer is found early, and if it is, then there's better survival rate with that. Otherwise, we will have to deal with the different emotional issues that the client may face, and making sure that you establish necessary nursing care plan, so appropriate nursing diagnosis for someone who is just recently diagnosed with cancer, regardless of what form of cancer. You think about helplessness, hopelessness, fear, fear of death, knowledge deficit, and so forth. Next slide. So you could use different, ways to bypass the bladder. So if the bladder is removed, we can bypass it. We can put stomas, and so forth. So in conclusion, bladder cancer is a prevalent disease with significant morbidity, right? So nurses should know and be competent about the information, because bladder cancer will help nurses. The knowledge, would help you manage the disease and the treatment complication, and of course to meet the patient's psychological needs. What I want you to do is to review the different type of ostomies, and the different type of reservoirs that are used for a patient that has bladder cancer, and compare and contrast that to reservoirs that are used for the GI system. Okay? Next slide.